Let me tell you what a real-life psychopath actually is. Not the fictional version. Not Hannibal Lecter. Not the cinematic serial killer with the cold stare and the elaborate ritual. Not the dramatic, immediately recognizable monster that film and television have spent decades teaching us to look for. The actual clinical reality. The documented, researched, forensically examined psychological profile that the science has been mapping for decades. And that looks almost nothing like the cultural construction we have been handed as a substitute. Because here is the thing about real psychopathy that makes it genuinely important to understand, and genuinely dangerous to misunderstand. The fictional psychopath is easy to spot. They are designed to be. The unsettling behavior, the obvious tells, the quality of wrongness that announces itself and gives you the opportunity to respond. The real psychopath, the clinical profile that the research documents across decades of assessment, interview, and longitudinal study, is frequently not easy to spot at all, is often specifically, deliberately, functionally easy to miss, is operating in ordinary environments, in professional settings, in relationships and communities and institutions, and is doing so with a sophistication that the monster framing actively prevents us from recognizing. Understanding the real psychology is not morbid curiosity. It is one of the most practically important things the forensic psychology literature can give us. Let's start with the clinical definition, because this is where the conversation needs to begin and where the popular understanding is most consistently wrong. Psychopathy is not a diagnosis in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, in the way that depression or anxiety or schizophrenia are diagnoses. It is a dimensional personality construct, a profile of traits that exist on a spectrum in the population, and that, at the extreme end, constitute what the forensic literature identifies as the psychopathic personality. Robert Hare's Psychopathy Checklist Revised, the PCLR, is the gold standard clinical instrument for assessing psychopathic traits. Developed through decades of research with incarcerated populations and subsequently validated across multiple cultures and contexts, it measures 20 items across two primary factors. The first factor covers the interpersonal and affective features of psychopathy: superficial charm, grandiose sense of self-worth, pathological lying, conning and manipulativeness, lack of remorse or guilt, shallow affect, callousness and lack of empathy, failure to accept responsibility for actions. The second factor covers the lifestyle and antisocial features: need for stimulation, parasitic lifestyle, poor behavioral controls, lack of realistic long-term goals, impulsivity, irresponsibility, juvenile delinquency, early behavioral problems, revocation of conditional release. The full clinical picture of psychopathy requires both factors, and the research is specific about what distinguishes psychopathy from the related but distinct constructs of antisocial personality disorder, narcissistic personality disorder, and Machiavellianism, all of which share some features but are not the same thing. What distinguishes psychopathy specifically is the combination of the interpersonal and affective features, the charm, the callousness, the shallow emotional world, with the lifestyle and behavioral features. It is the specific pairing of the capacity to read and use other people's emotional states with the complete absence of the affective resonance that normally makes that reading costly to exploit. Here is the neuroscience. Because the biological foundations of psychopathy are among the most important and least publicly discussed aspects of the research. The psychopathic brain is not the same as the typical brain. The neuroimaging research, and there is now a substantial body of it, documents consistent structural and functional differences that provide the neurological basis for the clinical profile. Kent Keel's extensive neuroimaging research with incarcerated psychopathic individuals, including the development of a mobile MRI unit, that has scanned more psychopathic brains than any other research program in history, found consistent difference in paralimbic system structure and function. The paralimbic system, the network of regions connecting the limbic system with the frontal cortex, is directly involved in the integration of emotion with cognition, in the process by which emotional information influences decision-making, in the capacity for the kind of affective resonance that most people experience as conscience. In psychopathic individuals, this system shows reduced gray matter volume, reduced functional connectivity, and reduced activation in response to emotional stimuli, including the emotional distress of other people. That in neurotypical individuals produces the aversive response that functions as a brake on harmful behavior. The amygdala, the structure most central to fear processing and to the aversive conditioning that allows most people to learn from punishment, shows blunted activation in response to fear-relevant stimuli in psychopathic individuals. This is the neurological basis of the fearlessness that characterizes the clinical profile. The reduced responsiveness to threat that produces the specific quality of physical and social courage, or, more accurately, the specific absence of the inhibition that fear produces, that many psychopathic individuals display. These are not learned characteristics. They have a neurological foundation that the research identifies as partially heritable and partially developmental. Here is the piece that the research identifies as most important for the practical question of recognition. The difference between the primary and secondary psychopath. The distinction, developed initially by Hervey Cleckley and subsequently refined through decades of research, is between psychopathy, that is primarily neurological in origin, and psychopathy, that develops in the context of severe early trauma and adversity. Primary psychopathy is characterized by the specific neurological profile we discussed, the reduced paralimbic function, the blunted amygdala reactivity, the constitutional absence of the affective resonance that most people experience as the foundation of moral emotion. These individuals are not distressed by their own psychopathic traits. They experience the world without the discomfort that the normal emotional architecture generates. Secondary psychopathy, sometimes called neurotic psychopathy, shares many of the behavioral features of the primary profile, but is driven by different mechanisms. The callousness, the manipulativeness, the antisocial behavior, these develop as adaptations to environments of severe adversity rather than as expressions of a constitutional neurological difference. Secondary psychopathic individuals often show higher levels of anxiety and emotional reactivity than primary psychopaths and are more likely to experience negative affect in response to their own behavior. This distinction matters enormously for the question of what psychopathy actually is and where it comes from. And it matters for the question of what, if anything, can be done about it. The research on treatment outcomes, which we will address, finds significant differences between these two profiles. Let me talk about something the research identifies that challenges the most persistent myth about psychopathy, the myth that psychopaths are primarily violent. The popular construction of psychopathy is almost entirely built around violent behavior. The serial killer, the predatory offender, the individual whose psychopathy expresses itself through the most dramatic and the most publicly legible forms of harm. The research on the prevalence and distribution of psychopathic traits in the population tells a more complicated and more important story. Robert Hare's estimates, based on decades of research across multiple populations, suggest that approximately 1% of the general population scores at the clinical threshold for psychopathy on the PCLR. That is a significant number of people, most of whom are not in prison, most of whom are not violent offenders. The research on what is sometimes called successful psychopathy, the expression of psychopathic traits in non-criminal, high-functioning contexts, is one of the most important and least publicly discussed areas of the clinical literature. Studies by Paul Babiak and Robert Hare on psychopathic traits in corporate environments found measurable rates of psychopathic characteristics in business leadership populations that were significantly higher than general population estimates. The charm, the impression management, the willingness to manipulate and exploit, the absence of genuine empathy for colleagues. These traits, in specific organizational environments, can produce career advancement rather than criminal conviction. The psychopath who finds a context where their specific profile, the fearlessness, the charm, the willingness to make decisions without the emotional cost that those decisions impose on most people, is rewarded rather than punished, is not the monster of the fictional narrative. They are the colleague, the manager, the leader who is producing results in ways that the organization either cannot see or prefers not to examine. Here is the finding on empathy that is most important for understanding the psychopathic profile accurately. The research on empathy in psychopathy is more nuanced than the simple absence narrative that the popular understanding presents. Work by S.E. Viding and colleagues on the neural and cognitive architecture of empathy in psychopathic individuals found a specific pattern. What researchers call affective empathy, the automatic emotional resonance that most people experience in the presence of others' distress, is consistently reduced in psychopathic individuals. The aversive response to others' pain that functions as an inhibitory signal for most people does not fire in the same way. But cognitive empathy, the capacity to model another person's mental state, to understand intellectually what they are thinking and feeling, is not consistently reduced in the same way. Some research suggests it may be intact or even enhanced in certain high-functioning psychopathic individuals. This is the distinction that makes the psychopathic profile specifically dangerous rather than simply callous. The individual with reduced affective empathy and intact cognitive empathy has the capacity to accurately model your emotional state, to understand what you are feeling, what you need, what your vulnerabilities are, without experiencing any of the discomfort that normally makes exploiting that understanding costly. This is what the forensic literature calls cold empathy. The cognitive component without the affective component, the map without the moral weight that most people's emotional resonance attaches to it. Let me address the question that the research takes most seriously and that the popular conversation most often treats as settled when it is not. Is psychopathy treatable? The traditional clinical consensus triaisoi, drawn from early treatment research with incarcerated psychopathic populations, was largely pessimistic. Some studies from the 1990s suggested that psychopaths who received treatment showed worse recidivism outcomes than those who did not. An alarming finding that suggested the therapeutic context was providing the skills to exploit rather than the motivation to change. The subsequent research has been more nuanced. The EQUIP program and subsequent structured cognitive behavioral interventions targeting psychopathic youth found more promising outcomes, particularly with adolescent populations where the personality structure is less consolidated and the neurological systems remain more plastic. Michael Caldwell's research on the treatment of adolescents with psychopathic traits found that intensive treatment produced significantly better outcomes than standard treatment, outcomes that persisted at long-term follow-up. The earlier the intervention, the more intensive, the more specifically tailored to the cognitive and motivational profile of the psychopathic individual rather than assuming the effective engagement that standard therapeutic approaches require. For adult primary psychopathy, the research remains sobering. The fundamental neurological differences that underlie the primary profile do not respond to the therapeutic mechanisms that most treatment approaches rely on. The aversive conditioning that most therapy assumes as a motivational foundation, the discomfort of guilt, of shame, of genuine empathic resonance, is not available as a change mechanism in the same way. What the research suggests is most effective with adult psychopathic individuals is not therapeutic approaches that aim to generate the emotional experiences the profile cannot access. It is highly structured, consequence-focused, self-interest-grounded approaches that work with the motivational architecture that is present rather than the one that is absent. Here is where I want to land. The psychology of real-life psychopathy is not primarily a forensic curiosity. It is not primarily the story of dramatic cases that make headlines and documentaries. It is the story of a personality profile, neurologically based, dimensionally distributed, present in approximately 1% of the population, that is operating in ordinary environments, in organizations, in relationships, in communities, that has a specific and distinctive way of engaging with the social world that the people around it are often ill-equipped to recognize. Because the recognizable features are not the dramatic ones of the fictional narrative. They are the charm, the specific quality of attention that feels like genuine interest and is not. The impression management that produces an image of competence and care that is extraordinarily convincing and almost entirely constructed. The pattern of behavior that becomes visible only in retrospect, when the specific damage has been done and the people who experienced it are trying to make sense of how they missed it. Understanding the research, The clinical profile, the neurological foundations, the distinction between primary and secondary presentations, the cold empathy mechanism, the organizational context that reward rather than punish the profile, is the beginning of recognition, not paranoid recognition, not the pathologizing of charm or confidence or the absence of obvious emotional distress. The educated, calibrated recognition that comes from understanding what the actual profile looks like in actual life. Because the fictional monster was never the danger. It was always the one you did not see coming.